So, welcome everyone, and thank you all so much for attending today. My name's Amanda Kelly. I'm the CEO of Women's Health Goulburn Northeast, and it's my pleasure to open the Long Story Short online forum. What better looks like transforming women's experiences through sexual and reproductive health experiences. On behalf of Women's Health Loddon Mallee and Women's Health Goulburn Northeast, I'd like to begin today by acknowledging the traditional custodians of the lands on which we live, work and play. We celebrate and respect the unique cultural and spiritual relationship that Aboriginal and Torres Strait Islanders peoples share with the lands, sky and waters, and the ongoing contribution their cultures make to the life of the region. As we pay our respects to elders past and present, we pledge our organisation's commitment towards reconciliation and justice. We recognise the strength and resilience of all Aboriginal and Torres Strait Islander peoples and are dedicated to a future in which they feel connected, empowered and safe within the communities of Loddon Mallee and the Goulburn Northeast regions. So today, we're here to discuss and share what we have learned through the Long Story Short project, a cross-region collaboration which aims to reshape the narrative of women's sexual and reproductive health. The many barriers preventing women from accessing services and information that enable timely, appropriate, stigma-free management of their sexual and reproductive health have been increasingly recognised by researchers, medical practitioners and the government over the past few years. The Victorian Department of Health and Wellbeing Plan from 2023 to 2027 and the Victorian Women's Sexual and Reproductive Health Plan from 2022 to 2030 outline the need for an approach to sexual and reproductive health that takes into consideration geographic, socioeconomic and cultural factors in addressing women's diverse needs across the state, acknowledging the social and structural barriers and enablers to good health, factors we refer to as the social determinants of health. The value of understanding the issues facing women through listening to their voices has also been recognised. This year saw the inquiry into women's pain, accepting submissions from organisations and individuals alike, highlighting the imperative to include the voices of women with lived and living experience in the efforts to address the gendered health inequity existing at a systemic and social level. We've just had some information about the survey, about the inquiry, and so there's been over 13,000 submissions, 40% of which were from rural and regional Victoria. So it's great to see that representation there. So the Long Story Short project of 2022-24 has focused on gathering women's lived experience perspectives, health sector expertise and quantitative data to go further than identifying the barriers to optimal sexual and reproductive health and wellbeing. Through this project, we aim to draw from women's experiences the solutions to overcoming these barriers, reimagining what could have been different or what it was that worked. Ultimately, we asked women to tell us what better sexual and reproductive health looks like. So I would like to thank the Centre for Excellence in Rural and Sexual Health for partnering with us on this forum, and our project team for their hard work and collaboration in bringing this piece of work to life. I will now hand over to our project team to present the report and recommendations. Alison.
Thanks, Amanda. My name is Alison Jones and I'm the mental health lead here at Women's Health Loddon Mallee and a member of the Long Story Short working group, which has been a multi-stage 2-year partnership project. At the heart of this project has been the lived and living experiences of regional Victorian women. We've adopted a feminist practice lens that has prioritised gender, human rights and the social determinants of health. Our approach has recognised the unique challenges faced by women living in regional and rural communities as well as the diverse experiences shaped by other intersecting factors. By centering these perspectives, we've aimed to amplify the voices of those often marginalised and oppressed by structural and systemic barriers. It is important to note that the term women in this presentation and report includes cisgender women, transgender women, and gender diverse people who identify with the female experience. The long story short project objectives were to undertake data analysis and service mapping activities to increase our understanding of women's SRH issues, to provide opportunities for women to have a voice in SRH service design and delivery, and to advocate for systems level change that will support the development of safe SRH systems that are person-centred, culturally appropriate, rights-based, and that meet the timely SRH needs of women. And it is wonderful to have so many change makers joining us today. I'd like to hand over to another project lead, Mary.
Thank you, Azzy. I'm Mary, Health Promotion Officer at Women's Health Goulburn Northeast. To drive the project, we formed a project working group consisting of Women's Health Loddon Mallee and Women's Health Goulburn Northeast staff who were responsible for the project's implementation. And to guide the project's development, we established a community advisory group consisting of 20 women and gender diverse people aged 19 to 67 years living in the Loddon Mallee and Goulburn Northeast regions, some of whom are tuning in today, and thank you so much for your involvement. We achieved the project's aims and objectives using a mixed method approach, incorporating both quantitative and qualitative research methods. This comprehensive strategy allowed us to build a localized evidence base very effectively. The quantitative approach included analysis of regional data profiling and conducting a desktop literature scan. The qualitative approaches included focus groups, consultation workshops, online surveys, and questionnaires. This gave us valuable insights into women's and healthcare providers' SRH viewpoints, opinions, and SRH experience living and working in our regions.
Thanks, Mary. Our community engagement captured the lived and living sexual and reproductive health experiences and perspectives of 80 women, gender diverse people, and healthcare professionals. Our consultation identified many barriers restricting SRH information and service provision within the Loddon Mallee and Goulburn Northeast regions. And this, alongside the poor socioeconomic conditions prevalent in our two regions, restricts women's accessibility to SRH services, intensifying SRH conditions and creating poor health outcomes for women. As health promotion officers, we adopted a strengths-based approach to empower our community by focusing on solutions rather than problems. We work collaboratively with women and healthcare professionals to identify opportunities for improvement. This approach allowed us to mobilise the collective wisdom and resources within our community to create lasting change. And our solutions are centred around 4 key themes: stigma and societal attitude, access and availability, quality of care, and education and awareness.
Yes, so through our community engagement, we uncovered a wealth of innovative solutions to improve sexual and reproductive health for women in our regions. These solutions demonstrate the power of collaboration and the importance of harnessing local resources. We have listened carefully to our community and identified 3 key areas of action using health promotion, acknowledging the socio-ecological model of health and the Ottawa Charter, where advocacy needs to be targeted and change needs to be supported. These recommendations relevant to a broad range of stakeholders from health promotion officers, community health workers, educators, general practitioners, and policymakers. There are recommendations for everyone working in the SRH space. Our 3 key areas for actions are creating supportive environments, growing a stronger evidence base, building healthy public policy. There are 39 recommendations in the report. We cannot cover them all today, so we have summarized them to give you a brief overview. We will start with the first set of recommendations, Azzy.
Thanks, Mary. Creating supportive environments. This first set of recommendations speaks strongly to what we heard from the regional women throughout the project. It includes increased access to stigma-free SRH services, increased SRH education so that young people are set up for success, they're informed, and they're able to access services and information. It also includes implementation of prevention programs and guidance on how all practitioners can ensure that they provide culturally safe care.
Our second set of recommendations speaks to the growing a stronger evidence base. Women want their experiences to inform and improve practice, and they want their practitioners to know more than just biological response to medical interventions. If women are to have improved outcomes, then we need more research that is informed by women's bodies and women's health. And if we build a collaborative partnerships, we can improve how we collect data and how we share our learnings throughout the sector. And the final set of recommendation is building healthy public policy. This set of recommendation aligns with the statewide initiatives and best practice approaches to build local capacity and improve access to sexual and reproductive health care.
These three sets of recommendations are the crucial building blocks for a healthier future for women in our community, and they provide a solid foundation for improving sexual and reproductive health outcomes in regional Victoria. We have got great representation here today from across the sector. Some of you are educators and health promoters. We've got practitioners and policymakers. So please do check out the report and spend some time looking at the recommendations and how you can influence their implementation in your area. We have an esteemed panel of experts with us today who are going to delve deeper into each of these areas. They're going to explore some practical examples and share their insights and expertise. But before we hear from them, I would like to hand over to Anne-Marie from the Centre for Excellence in Rural Sexual Health, because there's been some great steps taken in the sector that align with our recommendations. And Anne-Marie is going to speak to where we are collectively on that journey. Thank you, Anne-Marie.
Thank you. Now bear with me. I'll just wait for Frankie to stop sharing. Brilliant. All right, everyone, see my slides? I'm going to go with yes. Before I kick off, I also want to acknowledge the traditional owners of the land in which we all Zoom in from today. I'm here on the lands of the Dja Dja Wurrung people. I'd also like to pay my respects to any Aboriginal people we may have in the room. Thank you for coming along. So thank you for that brilliant introduction. My name is Anne-Marie Kelly, pronouns she, her, and I am lucky enough to work at the Centre for Excellence in Rural Sexual Health. So yeah, as mentioned, I'm just going to highlight some of the things that we can see across both Goulburn North East and Loddon Mallee regions that are occurring to support the recommendations, which is really fantastic. So at the Centre for Excellence, we are in a really privileged position. So we get to have a bird's eye view around lots of the fantastic things our communities are doing to improve women's health and sexual reproductive health outcomes. And we've been operating since 2009, and our core business really is around building rural workforce capacity. We also support through providing opportunities for knowledge sharing that empowers communities to take ownership over their initiatives and tailor activities that meet the local need, because we know that a metro response does not always work and most often will not work in our rural communities. We also work to enhance the rural SRH infrastructure. And what I mean by that is it's all the different nudge points that we can influence to get communities working towards a shared outcome of improved sexual and reproductive health. And of course, this is all made possible by funding from the Department of Health. So similar approach, looking at the themes that were met out of the recommendations. So some of the activities under creating supportive environments. So across both Loddon Mallee and Goulburn North East, SEARCH are lucky enough to facilitate some communities of practice, which bring community stakeholders from education, health, community services, our fantastic women's health services, into the same room to address, share, and formulate plans into how we can improve our responses into the needs of women and particularly their sexual and reproductive health needs. Over the last, I'd say, 18 months, we've worked hard to establish a sexual wellness action plan, which provides the framework to facilitate the activities. Previously, I'd say we all were doing fantastic work, but we didn't have the opportunity to come together to strategically plan and figure out where we can get the most bang for our buck, because it is finite resources. So by embedding a sexual wellness action plan across our different locations, it allows us to collaboratively plan to make sure that we're not duplicating in our space, to pool resources, as well as ensure that there's no gaps in what we're trying to achieve. The only location that currently does not have a sexual wellness action plan is Mitchell, but it is in the works. Another project I wanted to highlight that's working towards creating supportive environments is the Rural Services Development Project. Now, we're very, very lucky across both regions to have women's health funded hubs operating out of our community health services. But what we hear so often is it's really hard to operate under the financial model that's given. And that's because of the pressures of the MBS don't make it really sustainably viable to provide a long-term women's health hub in our regions. So what this project is aiming to do is to look at where we can create service efficiencies, leverage the MBS, grants, scholarships, and ensure that our hubs are able to thrive and be sustainable long-term in our communities. Because of course, we want them to succeed. It's fantastic that we have them, and we want them to stay and to be thriving and providing as many services and points of contact for women in our communities. Supplementary to this project, there are two other aspects which look at the mentoring and training pathways for providers. So we don't want this topic to be stigmatized. We want all our health providers to feel really confident and comfortable in providing safe, comprehensive women's health care. But that being said, accessing training in this space is quite complex because there are so many different training providers. So what this pathway model aims to do is to kind of see through the weeds and provide a path which is clear around the need to do trainings, which link to your certificates and registrations for clinical service provision, versus the nice to do trainings, which are your passion projects if you've got a special interest area. Following on from that, once someone, say, has gone through the pathway project, often we hear this lack of mentoring and opportunity to build confidence in the clinical space. We know our hubs are doing a fantastic job in unofficially being the mentors, but the problem with this is it's not recognised or reimbursed, and that therefore won't be sustainable long term. So as part of this project, we are wrapping support around our mentors and aspiring workforce to be supported to access these confidence building opportunities within practices, whilst recognising the time and the effort that goes into providing these mentorships, and hopefully in the end being able to reimburse and recognise all that fantastic work that's happening in the hubs, and in turn hopefully expand that and continue to build our workforce in our rural regional locations. In terms of growing the evidence base, we've got some fantastic work happening. Oh, sorry, before I move on. The women's outreach health clinics, the mobile health clinics which have been funded. So that state-funded initiative is fantastic for access to women's health services in our rural and regional locations. So this is something I really did want to highlight as a key piece of work that's underway in improving access for women in our locations. So moving on to the growing the evidence base, Women's Health Vic, the Atlas data is continuously being built upon, and they're doing some work at the moment asking stakeholders as to what data should be captured and would be useful for us to inform our activities. In addition to this, we're really lucky to have some fantastic local public health units in both regions who more often than not are willing to share the information so that we can inform activities that respond to the data. And I think that's really important. We know that this sometimes is a challenging topic to get on the agenda. So if we've got really great, robust data to support our arguments, it makes it far easier to set this as a community priority. And just finally, in terms of building healthy public policy, the municipal public health and wellbeing plans, which each LGA are responsible for reporting against, is an incredible avenue to push sexual and reproductive health and women's health. As a priority area, sexual health is often listed in there, but what we want to see is people signing up and putting their name to activities to deliver upon this. So I guess just in summary, these are the highlights, really, some of the fantastic work that is being undertaken in this space that's moving us forward in regards to the recommendations that we found out of the fantastic Women's Health Report. That was a whirlwind, but 10 minutes is a short amount of time when you're so passionate about something. So please feel free to reach out if you've got any questions around what I've presented today, and I will hand back to our facilitators. Thank you.
Thank you so much, Anne-Marie. That was a fantastic presentation. And it is absolutely wonderful to hear how much work is happening in the space and how that aligns to what regional women have told us. Before Anne-Marie's presentation, I spoke about some of our wonderful guest speakers who are coming in today. And our first speaker today is active in a number of areas across sexual and reproductive health education, fostering sexual and reproductive health and mental health literacy among young people. Jack Muscat, Legsy to his mates, holds the value of empowering others through knowledge, which is very close to his heart, leading Jack to become a registered paediatric nurse who now works across the Goulburn region in the Department of Education's school nurse program. Jack is passionate about harm minimisation and facilitating those tough but crucial conversations that can make a real difference in young people's lives, and is involved in the Man Cave, a mental health prevention charity that is helping boys develop the skills to live healthier, more emotionally intelligent lives through positive role modelling and workshops that allow these young people to explore healthier versions of their masculinity. Recently, Jack started Wise Ed, a Melbourne-based initiative delivering practical, youth-focused health education on topics like vaping, drugs, and sexual health. And it is my great pleasure to introduce you, Jack. Jack Muscat, over to you.
Hey, everyone. Want to acknowledge the 50 people in the room and wish everyone a healthy and welcome Sexual Health Day, internationally recognised on the 4th of September. I obviously have had a bit of a preamble on some of my roles working across state, but I really want to thank the Long Story Short project for actually inviting me along to talk about a few things. I do have two areas that I wanted to talk about. I was on a walk and talking to my girlfriend last night about, what am I going to actually talk about that will give some actual credence to the conversation? And I'm actually going to talk about my ex-girlfriend. Conversations that me and my ex used to have would be around like a lot of her pain, quite a lot of stuff happening during period times. Really interesting to see, I think, a bit of a lack of knowledge in local medical offices. She was in Warrnambool at the time, had really, really good support networks for some families, some medical people around. And obviously I'm in this space, and I remember saying, I think we really should try and advocate a little bit more. I think that we've got some more ammo in the chamber, and I think you've got a little bit more reason to push. Oh, but the pain, people say it's okay, people say it's not. And I remember obviously being in this role that we were pushing towards a little bit more of, okay, like, do you need some sort of contraception? Maybe it could help with regularity, maybe it could help with the actual flow, maybe it could help with the pain. Took weeks for a doctor's appointment, took a really long time. Also took quite a while for us to be able to obviously source a marina that we needed. And then eventually getting it done and getting the facilities and everything lined up together. It actually took quite a lot of work. I know that obviously we're talking about sexual and reproductive health today, but I think it is really important that we actually name sexual and reproductive health in a rural and regional setting does look a lot different to a metro setting. In that particular instance, we had someone who had really specific pain, obvious signs, and unfortunately there just wasn't the sexual and reproductive health education out there with their medical professionals to be able to deliver what they needed. We had a really good time. The doctor was so lovely, let me cut the threads off the marina. I've still got the pair of scissors, if you'd believe it. But moving on from that, I know that one thing that we're really seeing as being difficult in particularly the Goulburn region, we're seeing a lot of issues with that systemic sexual and reproductive health advocacy education and where it exists in our actual working life. And our working life is not with us as educators and professionals. It's actually with the clients that we work with. For us to actually be able to have successful outcomes and be able to advocate properly for people with significant pain that are often ignored, we need comprehensive and accessible resources, and we need some culturally appropriate stuff. Culturally can be Aboriginal and Torres Strait Islander. It can obviously acknowledge ethnic and diverse backgrounds, but it actually needs to acknowledge the cultural power of women. Cultural power of women seems to be ignored in a medical sense, particularly with a gender pain gap and the medical misogyny that often comes along with being misdiagnosed and dismissed. Importance in advocating for those better services in the regional areas, huge, but also urging collaboration between healthcare providers, community organisations and policymakers. First time that I met Anne-Marie, she said, "Where have you been? Why have you not been around?" And I think it's actually incumbent on places like Sersh, Loddon Mallee, getting people together who are big on this stuff is so important for the actual currency and what we're working with. I do want to take a bit of a pause. I'd love for everyone, we've been sitting down for a while, just to actually take a second, sit up in your chair, have a bit of a breath. There's one thing that I do want to acknowledge in this conversation around women's health. No one's actually said the word for it yet, but it's really important to acknowledge this when it comes to women's health. And the word is men. Addressing the harm and opportunity that men have in women's health, especially sexual violence, especially consent, in that impact long term. I do a lot of work with the Man Cave. The Man Cave is essentially a mental health charity that goes to schools, helps educate young men on how to actually build a bit of emotional literacy within. We have a lot of opportunity with young men to try and get in a little bit early and prevent some of those, not Andrew Tate and not that extremist behavior, but actually trying to get young boys turning into men that can help out and actually advocate for women long term. A lot of initiatives that we've got within the Man Cave is actually just giving young boys the opportunity to talk about themselves in a safe manner, use some of the emotional literacy and rich literacy that young men have, and actually be able to advocate that moving forward into how do I care for community? Yeah, community, okay, population of the world, 49.6% are men, 50.6% are women. If we're not actually looking after the people that create us, why are we not servicing ourselves? By servicing women, we service ourselves, and by looking after women, we're looking after community. A lot of initiatives within that, we see like a lot of impact where we actually get nearly 95, 96% of participants seeing that they have impacts from preventative mental health programs. Part of the reason I've sort of shifted into this work is, I was on the wards at the Royal Children's doing a lot of reactive work. But for me, I think that one thing we need to focus on is that proactive work. If you can get in a little bit early and you can try and start that positive male engagement with actually having some good male role models, I challenge you to think of some. We can actually get a little bit more buy-in and a bit more currency from young men. And in that, we can actually get people and young men looking at what is a healthy man? What does it mean? If I actually talk to some of the systemic factors that are contributing to violence against women, it's kind of men. Yes, I do want to acknowledge that there are lived survivors that identify as male, but we need to seriously acknowledge the voice and the tangible currency that comes from women self-advocating for their health. Obviously, we're talking in a sexual and reproductive health sphere, but I do want to bring this men's health area in because I think it's really important that we do actually meet in the middle of both of these. I think that it's really important for us as men to acknowledge that there's such opportunity for us to give women's health a red hot crack. Me, myself, men's health, I've got an easy job. I go to the doctors, I say I got a sore foot, cool. Woman goes to a doctor, woman actually goes in and says, I'm acknowledging some pain. When we talk about the pain gap between men and women perceive pain differently. When we talk about the actual, we talk about the, I guess, the gendered, how would you say? We talk about the actual gendered health education equity gap that might exist between some healthcare professionals in regional and rural areas. They might not actually have the literacy to be able to talk about some of that stuff. I think a lot of what we can do in sessions like this is actually give space for us to address some of the actions that we can take as community, professional, private, to actually improve the sexual and reproductive health services that we have at large. Yeah, acknowledging men's health and men's emotional literacy in that space is enormous. And in particular, having good male role models come in and participate and give sex ed. Having men who are actually passionate in the area of caring, I think super important. And on the other hand, actually having really, really solid education, access. I want to make sure that we have a world where we've got women that are listened to, cared for, and actually living their best lives. It's time to actually call out where we can enhance that education and advocacy and create a safer environment for women, a women-led future where they're flourishing. That's my little spiel from as we were saying before the session, a poor man's Chanel Contos. But anyway, I might hand it back to the facilitators. Thank you.
Thank you so much, Jack. What a wonderful presentation. And you talked about thinking about role models, and it's such a privilege to have one here and yourself here today. Thank you so much, Jack.
Thank you.
Our next speaker is from our very own Long Story Short team. And she is going to speak to the importance of ensuring equity and lived experience and how that informs data collection, research practices, and information sharing to strengthen the evidence base around sexual and reproductive health solutions. Catherine is the Regional Coordinator of Policy, Advocacy and Communications at Women's Health Goulburn North East. Her background as a feminist labour historian, researching and publishing work on women's class-based activism in mid-century Australia has imbued her work with the women's health sector with a deep understanding of the incremental nature of systemic change, alongside a drive to continue advocating for increased economic and health equity for regional Victorians. Catherine has worked on a number of community consultations and translated knowledge in the areas of workplace gender equity, the prevention of gender-based violence, and sexual and reproductive health. Thank you, Catherine.
Thank you so much, Alison, and thanks, Jack. That was amazing. As part of the Long Story Short project team, it has been my privilege to engage with women across Northeast Victoria and the Goulburn Valley to better understand the nuances of their lived experiences with sexual and reproductive health. Research has such an important role to play in improving our healthcare system and growing a more equitable and diverse knowledge base from which to draw. We need to think critically about the settings and ways in which all kinds of research is collected, shared, contextualised and translated to ensure we're building a knowledge base that is truly representative of the needs of communities across Victoria and accessible to people inside and outside of academic and medical circles. So a key recommendation within the report, as you've heard, is around collaborative partnerships for data collection and dissemination of key sexual and reproductive health learnings. The collection of qualitative data must be considered through an intersectional lens from our point of view. Research partnerships fostered to reach different cohorts can be identified by asking questions like which organisation has built relationships, is embedded, has earned trust with a given community, and And also, how can we collectively support the capacity of organisations and individuals representing marginalised communities to undertake qualitative research that is equitable and, as Jack said, culturally safe? As health promotion organisations focused on addressing the social determinants of health, the women's health services in Goulburn North East and Loddon Mallee hold the value of lived and living experience as central to contextualising the quantitative, demographic, geographic and socioeconomic data pertaining to our rural and regional catchment areas. So to give you an example of what I mean, it only tells us half the story to know, for example, how many health providers per 10,000 people are operating in a local government area. Lived experience data fills in those unknown factors. What is it like to access this or that service in your small town? If you have the means, do you travel to the closest regional town, which might be in the neighbouring council or even across the border in New South Wales? What are the barriers and enabling factors not shown within the quantitative data? Partnerships between health promotion organisations and institutes like SERSH are crucial to the process of knowledge translation. During our focus groups, women told us the importance of being communicated with in accessible, jargon-free language in order to engage with up-to-date information and research about their sexual and reproductive health. This is something that we have considered in translating the findings of the Long Story Short report for a broad community-based audience on down the track. So the women we spoke to during the project's consultation phase were very interested in accessing information informed by the latest research around topics like contraception, menopause, and treatments for pain and endometriosis. They were curious to know if their health providers had processes for keeping up to date around medical research, but also about complementary treatments and specialist services in their region. Rather than being siloed, women saw a great value in information being shared and widely disseminated among healthcare professionals and the people to whom they provide care. While the recommendations within the Long Story Short project advocate for the broader accessibility of data and research pertaining to regional factors, we also believe it's imperative to address the question of equity and bias within research practices more broadly. Many of you may be aware, or I'm sure you are aware, that women's bodies were excluded from medical research and that sexual and reproductive health has often focused solely on women's capacity to bear children. While in recent decades, there has been a concerted effort to address this gendered discrepancy in research subjects and broader acknowledgement of the varied nature of sexual and reproductive health, there are still areas within the healthcare system that are residually impacted by gender biases and a missing emphasis on the impacts of biological sex and gender on health and healthcare. The Victorian Government's Our Equal State, Victoria's Gender Equality Strategy and Action Plan 2023 to 2027 requires all Victorian government-funded health and medical research to be conducted through the lens of biological sex, gender and gender diversity proactively throughout the research process. I would propose that it would be of amazing benefit if this kind of policy was adopted as a standard at a federal level and by private funding bodies, research institutes and publications. Indeed, this drive towards greater consideration of biological sex and gender, as well as gender diversity in research, has been gaining momentum for some time now. In 2019, Australian medical academics ran an advocacy campaign for research funding agencies and peer-reviewed journals to improve their policies on the collection, analysis and reporting of sex and gender-specific health data over concerns that Australia as a country was falling behind the international community. The uptake of such policies remains at the discretion of independent organisations and can be identified through individual organisations' policies. You can dig through them on their websites. But in order for a better collective understanding of where the existing gaps are and how to address them, we need accessible information on where to source sex and gender disaggregated data, which research organisations embed equity in research, how and where advocacy drives change in this area, and the long-term growth of positive sexual and reproductive health outcomes as the body of research into health, sex and gender becomes more accessible. Monitoring and evaluation can play a fundamental role in sort of understanding where these gaps are and how to address them. One data gap, which has been the topic of recent public discourse, is the need to collect demographic data pertaining to gender diversity and sexuality. Without the collective effort to ensure inclusive research policies and practices are standardised, we will not have the full picture when it comes to the information and service needs of communities accessing sexual and reproductive health care. Alongside collective advocacy to embed gender equity within health and medical research, collaboration between sectors and organisations on meeting women's sexual and reproductive health needs in regional Victoria relies in part on information sharing and research translation. Together, we can improve health literacy, increase the accessibility of sexual and reproductive health expertise, and generate solutions to the systemic barriers facing women and gender diverse people in our region with the backing of best practice sex and gender disaggregated research that is readily available, and also the continued inclusion, importantly, of diverse lived and living experience in the evidence base.
Thank you so much, Catherine. Great presentation. And it was great to hear some fantastic responses to what we heard from women in the room, feeling like they're women and gender diverse people, really feeling like they weren't represented in the data that is put forward. Our third and final speaker today is Associate Professor Siobhan Bourke. We are thrilled to have Siobhan here with us today for her expertise and passion in the field of sexual and reproductive health. Siobhan is a sexual health physician with degrees in public health and clinical education. She currently works at the University of Melbourne in two roles: at SERSH, coordinating the new medical doctorate sexual health elective subjects over years 1 to 3, and is the director of the Sensitive Physical Examination Program in the Department of Medical Education, teaching genital and breast examination to medical students. She works clinically at the Community Health Centre in Western Melbourne, working alongside one of Victorian government-funded sexual and reproductive health hubs. Thank you, Siobhan.
Thanks, Alison. I'm just going to share my slides. Okay. All right. Just need to move this. Okay. Thank you, everybody. So fabulous to hear other speakers. I just wanted to sort of deliver a talk on what we're doing with the medical students, but lead you into how we kind of got there. So the subject that I run at Melbourne University for the medical students is called Sexual Health Across Clinical Contexts, and I'll explain why I called it that slightly boring name, but there is a reason behind it. Before I start, I'd just like to acknowledge that we're meeting on the unceded lands of First Nations people. And I really want to acknowledge that learning stories, yarning, has been going on for over 60,000 years. And I hope that with our education, we're continuing that process. So Anne-Marie has spoken to us a bit about what SERSH does, well, a lot about what SERSH does, and the little bit that I do, I think aligns with some of the recommendation and goals from the long story short, in particular supporting the implementation of statewide Victorian women's sexual and reproductive health in the plan. And the other one I think we really are aligned with is the support of the implementation of statewide Victorian women's sexual and reproductive health plan by building local workforce capacity. The building of local workforce capacity has been central to my role in the education of people out in the Goulburn Valley and in the Hume and Loddon Valley, but also statewide when I look at the medical practitioners that can access our health online education. And also the fact that people can do the online education can come from absolutely anywhere. So we have had people do them from overseas and Western Australia and all sorts of places. So I think addressing the needs for best practice sexual and reproductive healthcare, we have to take into account that we need to understand the communities that we're delivering the education to, that we deliver this without assumptions. That's out assumptions for the patients that we will be serving or caring for, but also without assumptions around the people who are doing the education themselves. We're trying to remove the barriers of access, cost, travel, and ensuring that there's a comprehensive understanding of need within the communities that we're delivering to. Why is it that it's such a problem for most people to actually deliver sexual health care? And I think sex is one of those things where no one wants to be wrong. There's a lot of other areas of our lives where we don't mind getting it wrong because we don't need to be an expert banker or we don't need to be an expert cook or something like that, but no one actually wants to admit to getting sex wrong. So we often avoid the topics that makes them uncomfortable to discuss. And so therefore, I think our role is actually in addressing this. The ways that we've been addressing this in SERSH, in my role, is that we've actually looked at registered health professionals and providing free and online education. So the importance about that is that it can be done in a timely manner whenever someone else is, when the health professional is available to do it. It's not that they have to turn up, get backfill for their position, they have to travel, etc. And we're lucky enough to be able to provide this free without people actually having to pay for it. So I think that's reduced some of the barriers for health professionals accessing our education. We also have been lucky enough to address some pre-registration health professionals, and so that's where delivery of the subject that I'm running comes into play, in that we are looking currently at the medical students at Melbourne University. So what really happened was happily providing online education for health professionals through SERSH, and then an opportunity came where the University of Melbourne redesigned their medical degree. So it's a postgraduate degree. They redesigned it to include elective subjects. So the students all do elective subjects, and that's where we attempted to address the sexual health care needs for patients, and so therefore teaching the students about the sexual health care. So the degree is a 4-year degree. Each year the students have to, all the subjects add up to 100 points. It's just the way it works. And we provide a subject in year 1, 2 and 3 that is 1/8 of the course. So the rest of the course is the core of the medical degree, but we're providing 1/8 to a select amount of students, not to all the students. So it just depends on how many students choose our subject. So we designed, developed, and now manage and deliver to provide sexual health across clinical context. So the reason that I called it this was I wanted to get across that it's practical and relevant and that can come across any clinical context. So it doesn't have to be in a general practice. It doesn't have to be in obstetrics and gynecology. It can be anywhere. And the fact that sexual health is an important element to all of our lives, we need to be able to address those things to be able to treat the whole person. So all the subjects, when we run them and put them forward, they have to be declared as inclusive of diversity, and they have to be appropriate First Nations teaching. And those are both signed off by the whole Department of Medical Education. We do have another subject that addresses sexual health, and so our subject sits along a subject called the Rainbow Mole subject that the First Nations Health Unit has put forward. One of the things that I think is the most important thing about sexual health is learning to be able to communicate So throughout the entire course, communication is actually the key. We know that the research shows us that patients think the doctors should bring it up, or the health professionals should bring it up, and the health professionals think the patients should bring it up. My thing is, we're health professionals, we need to be able to bring these topics up. And so teaching people to be able to communicate is the fundamental thing. If there was one thing, if I was only allowed to do one thing in this whole course, it would be teaching people to be able to have the conversations and take a really good sexual history and break down the taboos of talking about sex. So I'm an extremely practical person. So everything that I do has some sort of practical and relevance. And you get sick of seeing that thing across my slides. So just to take you through what we are teaching the students. So we have synchronous learning and asynchronous learning, which the synchronous learning just means they're face-to-face. And the asynchronous is online and they can do it whenever they like. But the fundamental thing that we addressed was that the students need to have the same experience regardless of if they are sitting in a metropolitan position or whether they're rural. So we do, every time we run our course, we run it to the metropolitan students and we run it to the rural students. They get the same experience. So we look at sexual health research, history taking, and we do that in very small groups so that the students are taught in a safe space and they get very used to. It's quite amazing to watch the medical students in first year going from struggling to say penis, clitoris, vagina, whatever, to asking really intimate and quite challenging questions. And it's a joy to actually watch. The asynchronous, moved on. Why hasn't that moved on? Okay, there we go. So the asynchronous learning, we have the modules online, which align with the search modules. So I do use the modules that the practitioners have access to also for the students. And we set up, every time we do an assessment, it needs to be relevant and practical to their future. So the first assignment they do is literally a video of themselves taking a history. So I like to set things up as being extremely practical. We also have themes across each of the years, and the first one is breaking down stigma. So they do a reflection piece on stigma. So in the second year, the synchronous learning is around interprofessional care. So understanding that the medical people are not just working by themselves, but the sexual health is addressed across all types of specialties and allied health, whichever you want to call it. We do have a really big focus on genital anatomy, and this is where a lot of the women's sexual and reproductive health comes in for us, is during this session where we talk about genital anatomy. And what we've done is we've flipped it. So if you look at any anatomy book, it starts off with male anatomy and they'll get a page or two, and then female anatomy gets a sentence or a paragraph. We now actually flipped it and we talk about female anatomy first and the variations on it. We also talk about pain syndromes, particularly related to the vulva and dermatology. And in the middle of all this day, which is a pretty heavy day, we bring in the ideas around sexual arousal pathways, just to make sure that we're not just focusing on disease and the problems, we're focusing on the fact that this is the way people get aroused, this is how you get pleasure, and to start people thinking about sexual health being more than just talking about what's going wrong, but actually talking about having successful sexual careers, whatever you want to call them. We do also talk about sexual difficulties and dysfunction, and then we get the students to completely practice an STI consultation, which includes, as I run the sensitive physical examination program, where we teach the medical students to examine genitals and breasts. And what we've done is that we get them to repeat the genital examinations, so that the students in our cohort get to do them twice. And then we've also added in the new vulval examination. So nowhere else in the world are medical students taught how to actually examine the vulva. And so we've created a whole new examination tutorial on this, which has been absolutely fabulous. Then we start talking about some more complex issues related to consent, capacity and mental health. We do a health promotion unit where the whole SERSH team comes in and the students are absolutely fascinated. We call it health promotion, not just handing out a pamphlet. And we talk about all the wonderful projects that people can be involved with. And then we start talking about complexities of care, and we do this through transgender medicine, HIV and alcohol and drug. And so that's a great workshop where the students realise how sexual health can be related to multiple issues and how we take care of patients with really complex needs. And once again, the assessments are really practical. They have to write a referral letter for their first assessment, and then we do a modified long case, or like an OSCE exam, where they get to present a case. They do an examination and they have to answer a lot of questions. And the students love that, not only for the practicality related to sexual health, but they say it's a really good help for them practicing for their OSCEs later on in the year. And in the third year, that we do a lot of stuff on contraception, and so how to choose contraception, and then we also do in-depth discussions around Implanon and IUDs. And from the end of the Implanon training, the students actually have a certificate, which means once they are graduated, they are fully certified to actually be able to provide, insert and remove Implanons, which I didn't realise how much this would thrill medical students to actually hold a certificate in their hand that's real, but they've really enjoyed that. We do concentrate a lot in the third year on medical abortions, and then we tackle once again some of the more obscure and more challenging subjects around non-consensual sex and coercion, talking about sexual health, ageing and disability. We have a session about working with sex workers, STIs, sexual health and travel, and then also sexual health education, on the premise that someone somewhere might ask them to be involved in educating our young people. And the assessments, once again, focus on things that are really practical related to Implanon training and also doing more case study work. We're concentrated here on being a future practitioner for their reflections. So just for some of the innovations, we're teaching medical students about sexual health. We're teaching sexual health care. We're teaching medical students across 3 years. That doesn't happen anywhere else in the world. We do a lot of small group activities, face-to-face. We have the vulval workshop and examinations where they're really getting to understand variation of anatomy and vulva. They're getting to understand how to examine a vulva properly. And then they're talking a lot about issues related to pain, etc. And one of the other things is that we've looked at consent and capacity from a legal framework as opposed to a medical framework. And so the students find this really quite innovative. Not long to go now, sorry, death by PowerPoint, which is a really bad thing for an educator to do, but I just wanted to show you how the confidence in sexual history taking flips in just short 4 weeks of having some concentrated small group tutorials. And I think this is, shows the real relevance, and then really to highlight some of the feedback. Not all our feedback is fabulous. People are asking for different things, but we do get a strong sense of the students feeling like their confidence increases, their capacity to provide sexual health care increases, and they really just quite enjoy the subject. And one of the big themes is to actually that they all think that this subject should actually be in core, which I think is something that's really important to think about. And so I'd like to highlight to the students that the sexual and reproductive health care is very important for all people. There is a burden on women and non-binary folk or gender diverse folk. And really, if I could do one thing, it would be to make people have conversations and learn how to communicate. And I think this really loops back to the recommendations from the report about building healthy public policy to support capacity building of the workforce. I think us having the conversation needs to lead into students having the conversation, and I highly recommend that people get this sort of education in all types of health modes. And I just want to recognise that a lot of the time people haven't been taught enough in school leading into this, and that the medical students are no different. And I presume that that's the same for all other health realms. Thank you. I'll stop sharing. Sorry if that went over time.
Great. Thank you so much, Siobhan. I am a different person. Hello. Ash Colhoun is my name. I use she, her pronouns, and I'm one of the project leads at the Centre for Excellence in Rural Sexual Health. It's my pleasure today. I've been asked to facilitate our panel discussion, which I'm really looking forward to. Thank you to everyone who submitted questions in advance via the Eventbrite. If anyone has any other questions that they'd like to ask of our panellists, if you could please use the Q&A function or use the chat to put those questions in there. I would like to invite Siobhan, Catherine and Jack to turn their cameras back on. Great, thank you. It was wonderful hearing from all of you, especially being so solutions focused, looking at the recommendations in the report and what things we're already doing and what we can be building on. Jack, the first question I have is for you. One of your roles and your many hats is as a school nurse. What do you think the optimal role is for school nurses or other professionals who work with young people in sexual reproductive health education?
Good question. Very good question. Spitballing, I'd say, I mean, I've worked with probably coming on 1,000, maybe more kids. Honestly, and not to use like the young people vernacular, I think actually having people that are providing expert aura and actually people that can really role model, I think really role modeling healthy femininity and healthy masculinity, massive. And whether or not you want to call that actually maybe like the next step of that from, your healthy masculinity to actually being integrated masculinity or integrated femininity. I think, providing that real expert level of work, authority, gravitas, actually working a little bit further in the weeds and doing some more preventative programs. I think it's important that we work with people. We want to work with people before they form maladaptive and negative behaviors, and actually getting into them before they've got those negative worldviews, negative world practices. The more that we leave them alone on the internet, whether that's subject to porn or that's subject to our good friend Andrew Tate, those things can really seed in their minds some very strange and honestly scary outcomes for other men and for women as well, and for themselves. I think if there was another optimal role, it would actually just work at that emotional literacy and that emotional currency. When we build and invest in the social workings of us, it benefits everyone. And it's not just in that health realm. Like obviously you're going to be seeing a lot more poignant development in an individual. You're actually going to see their whole community benefit from it as well. So if I had to really give you an optimal role, I'd say be an expert, work in preventative, be that proactive rather than reactive. And work to build emotional literacy. That's what we're trying to do.
Yeah. Great. Spitballing, that was an excellent answer to that question.
No worries.
Siobhan, you mentioned teaching arousal in the sexual health subject. We know that pleasure is often not considered in sexual reproductive health. How do you think in a healthcare setting we can extend beyond that reproductive focus to be more holistic and to include pleasure?
I think as I said before, I think one of the things is that we have to start these conversations. So the health professional has to become literate and be able to have these discussions. But I think one of the things is to actually take a whole person history in a healthcare setting, which doesn't just include what's going wrong, but also, you know, what's going right, where are their strengths, and whether they, you know, we need to start having the conversations about whether they actually enjoy having sex, and trying to lead out patients kind of down that line. And so I think therefore we need to kind of go a step back, which I think also, you know, everybody else has been talking about, is we need to actually become literate ourselves. And how is it that we can actually talk about things? It's supposed to be fun. The other thing is that I think we need to be relatively conversational, not just, you know, when I say history taking, I really want people to have a sexual health conversation with their patients, and be able to discuss that, you know, sex is supposed to be fun, and therefore when we're having those discussions we can actually be a little bit fun. People learn when they're having fun, and so therefore our patients can feel a bit more comfortable and relaxed if we can make our conversations a bit lighthearted, serious when they need to be, but also to involve those aspects and discussions around pleasure. Did that kind of... The other thing I wanted to add around is having fun is actually using props. And so I often have things in my rooms so that people can actually ask questions about it, or I can actually bring questions up. So I have things like vulvas sitting side. I have the other prop that I only had today at home is a mirror, and talking to people about how it is that we use a mirror, and so that you can actually look at the examination that I'm doing. Now, this mirror is actually a mirror that you can buy from an automotive shop, which is funny in itself, because this is what you do to check under your car. Now, I'm not suggesting that we need to change that, but you know, you have a mirror and you get people used to saying to their patients, I'm going to examine you, why don't you hold this and then you can see what I'm doing. Particularly important for women. So I think just things like that, making it a bit lighthearted, but also having the conversations and talking to people about pleasure, explaining the clitoris. I mean, we all need to know about the clitoris, and so this is why I use this model, because I can take it off and show people where the clitoris sits. It's very hard to do in this, where the clitoris sits, and we can then talk about the clitoris and how much bigger it is, and it's not just the knob at the end. And so I like to have things where I can really explain it. And also, I think sometimes that can make it easier to focus the person onto something rather than looking me straight in the eye, but we're having a conversation, and I will talk about, you know, those sorts of things and bring it up. While I'm putting local anaesthetic in to put an implant on in or put an IUD in, we've got a few minutes while that's working, let's chat. And I just start talking about anything. So I think that's another useful way, is just sort of make it conversational.
Yeah, great. Thanks, Siobhan. I imagine that would be quite empowering, even just having that mirror and be able to see your own body and the examination that's happening.
Yes.
Jackie, do you have anything that you wanted to add in the way like SIH is taught to young people when we're having that conversation around pleasure?
Oh, mate, the pleasure conversation just doesn't come up. And it's quite frustrating as someone who wants to have those conversations. Look, full credit to Department of Ed. You know, sex ed curriculum is in a really good place. The things that we deliver on are really good. If there was a small part, it would be that physical pleasure talk, because it's really hard to have a nuanced conversation about pleasure with children, obviously. But simple stuff like pulling out the doll and showing a clitoris looking like actually quite a large piece. Oh, why does it look like that? Well, you know, when you see something that goes into the, you know, into the vagina, we're seeing things actually rub on the side, you know, like actually talking about the mechanics of pleasure as opposed to just it's assumed. I think that there's a place for school nurses to have those conversations because we're a bit, a little bit less tied to that curriculum.
Yeah, for sure. Thank you. Catherine, I've got a question for you. In the Long Story Short project that you've obviously been a part of for the last couple of years, what did you identify, or what would you say are the three biggest issues facing women in sexual reproductive health for Goulburn North East and Loddon Mallee area?
Thanks, Ashley. Yes, I would say the three biggest issues, and it's hard to sort of clump everything together, but I would say issues of access, which is fairly broad. So access to GPs in terms of cost, affordability, bulk billing, access in terms of wait times, access in terms of short appointment times, things like that. But then also, obviously, in the rural and regional context, there's travel, especially for specialists. So I would say, in terms of solutions to that particular issue, we've heard some today, like around the travelling health services, really great in rural areas. And then, so the next one I would say would be quality of care. And that's, like all those things around women sometimes feeling dismissed, sometimes feeling disrespected during consults, but then also on the other side of the coin, women often talked about how great their experiences were when they did have a healthcare provider who they felt listened to them and who was engaged with sexual and reproductive health, and as Siobhan said, started those conversations and helped them to sort of express themselves, even though they might have been feeling a bit embarrassed at first. So I think some of the solutions to these problems have really been presented today by our other panelists, in terms of that sort of sensitive care training, and it's really great to hear. And then I would say the third issue is around health literacy and education, where to find information, and that also ties in with the sort of shame and social stigma that people are exposed to growing up quite often. But yeah, we heard a lot about people not being quite sure where to find resources, or there being so much information, but they didn't know which ones were the sort of credible sources. And I think that comes down to that knowledge translation part again as well, where we need to have really plain language resources that tell people where they can go for services, and also give them basic information about their sexual and reproductive health.
Great, thank you, Catherine. Yeah, so access to care, quality of care, and then that health literacy as well. Siobhan, it sounds like the next generation of doctors are going to be very skilled in sexual reproductive health care, but what would you say to the current workforce? How do you think that people who are currently working in sexual reproductive health are able to upskill themselves?
Yeah, I think most of it has to be self-motivated, which is unfortunate. Like, this is why I'd really love to get it into core for the pre-registration doctors or health practitioners. Most of it has to be self-motivated. And I think there is a lot online that you can learn. I mean, CERT has our online modules. There are specific courses, and but some of those barriers can be travel, etc. And I think then there are some things where finding a mentor can be a bit of a difficult process, but there are networks of people who are interested. There's a sexual health interest group from the Royal College of General Practitioners. So you get sort of different groups, and it's sort of a matter at the moment, I think, of finding your people, and then that mentorship to be able to say. So one of the things I find with the medical students is they really think that they're going to graduate and they're out there on their own, and so I try and sort of inspire them to say, no, you don't have to do this all. This was the whole point of writing a referral letter. So you've got an issue, you've sorted most of it out, but you need to direct the person into another position. And then also when we do the case study in third year, and it's quite complicated with a young person, an unplanned pregnancy and some form of abuse, it's all about and I said to them, this is a complicated case. You would talk to your colleagues about this if this person came into your room. So trying to get people to make those connections. I suppose one of the things from the women's, they have the clinical champions. And so that's around making those connections, getting into do small group learning. So I think, unfortunately, I think it has to be quite self-motivating at the moment. And which is good because you get people who are passionate, but it also means that something that should just be general is missed by a lot of people who don't have the confidence to take this on as a challenge to increase their care of their patients.
Yeah. And if there are health professionals that are listening to this, so you mentioned the search modules, RACGP, if someone's going to do a quick Google and they want to upskill in sexual health, where would you be wanting to refer people?
Well, I would definitely say to the search website and have a look at our set of modules. We've got 12 of them. And if you only do, well, if you do 2, one of the things I forgot to mention was we get the students in first year, the medical students in first year to listen to some of our modules. And one of them talks about what is the difference between rural and metropolitan healthcare. And it's really interesting. The rural students are like, oh yeah, whatever. And the metro students are like, wow, I just thought it was just going to be a smaller version of what goes on in town. So I think, you know, if you were going to do 2 of them, you do the first one, particularly if you're not a rural practitioner, and then the cornerstones of sexual health care, because that is around talking to patients. But we have a variety of different things. There's also, and I can see the search website's been put up in the chat. We also, Sexual Health Victoria provides a really comprehensive sexual and reproductive healthcare certificate for both medical practitioners, and there's a nurse's course. So I think places like that do, you know, reputable courses are really you know, are probably the mainstay. And obviously when people get really excited about it, they can become a sexual health physician, but that's a full training program. So, and I think it's currently on top of having already become a GP or another physician, you do an extra 2 to 3 years on sexual health.
Thanks, Siobhan. Referring to the report, I hope that you'll all be able to go away and read it. But I know in there's some great stories of the experiences of the rural regional that is so different to metro. Catherine, I had another question for you, which is, I know you touched on this a little bit in your presentation, but if there's anything specific you could say that you heard from LGBTQIA+ regional people or women or gender diverse people.
Thanks, Ashley. Yes, we did hear from some women who identified as LGBT or part of the LGBT community. And really what we heard specifically, it was around that quality of care piece. And so basically they told us that they want their healthcare providers to be proactive in researching and implementing inclusive practices, trauma-informed care, and to respect sexuality and gender identities. So we did hear a few stories about, you know, women who were repeatedly asked things like, oh, could you be pregnant, when they presented with symptoms after they'd mentioned that they, you know, were lesbians, things like that. And so, like practically all women we spoke to, LGBT women wanted to be listened to, wanted to build a rapport with their healthcare providers. They said that even simple things like asking for pronouns as a matter of course in a practice, or displaying pride flags, offering information designed for LGBT communities, made them feel more comfortable and accepted and included in healthcare spaces. So those are just some simple things that people can implement. And obviously seeking sexual and reproductive care, healthcare can evoke complicated feelings for trans and non-binary people. And I think healthcare practitioners who are aware of those factors and are making an effort to be sensitive, taking patient-centered approaches, again, as we've heard Siobhan talk about, can increase that quality of care for all patients, but particularly LGBT patients.
Wonderful. Thank you, Catherine. A little bit of a change of pace, but Jack, I've got a question here for you. Obviously, a strong push around consent education recently becoming mandatory in schools. Are you seeing a change as a result of this?
Yes and no. So I would say my reasoning for no is that if I was to give a yes, it would indicate that the needle has moved enough that we don't need to change. I think we need to acknowledge that, yeah, it's helping a little bit. So that's my yes. But my no is that there is just so much more work to do. And the affirmative consent model that's come out is awesome. And teaching it is actually really impactful. I'm loving the conversations that I'm having. I think the most tangible change that I'm seeing in the consent conversation in schools, like I'll throw you one example. So I was doing a sexual health workshop at a particular school, and we were talking as a group about some above the line and below the line sort of, like kind of what's a gray area and then like what's sitting here, what's sitting here. And so we were talking a bit about actual courageous conversations surrounding what are guys scared of, what are girls scared of. Guys in the room were sort of pretty quiet, and they were talking specifically about, just stuff that's sort of floating in the ether. And I asked a really direct question. I said, boys, I actually want to give you the opportunity because you've got a really cool audience here in front of you of lovely women that are going to listen. What are you guys worried about? And they were worried about being accused of something that they haven't done. And having, as a young man, having the literacy to say that is awesome. Like, it's a really good step. So boys, that's awesome. Thank you so much for acknowledging that. Girls, what's it like to hear that? Oh, didn't realize that's a thing. Hey, girls, like while we're here, can I give you the opportunity to answer that same question? What are you scared of? And the courageous conversation coming from the girls is, we're scared of being raped. We're scared of being sexually assaulted. We're scared of being harmed. Boys, what's it like to hear that? Oh, I didn't realize that was the impact that we have. Cool. Like, let's build a bit of a conversation around maybe where we're thinking we can actually have impact in the consent conversation. And another piece that I sort of raise after that, because it's happened a few times in my workshops, I talk about an experience I had when I was young where, I was at a party and was with my girlfriend at the time, it was year 12, and PDA was shocking. I can't do that. And I said to her before the party, look, I actually don't think I'm freaking out. I can't hold your hand. I can't kiss you at this party. I can't do anything. I've got to I've got to be separate. I'll be near you, but I can't do that. End of the party, everyone sort of gathers around, a nice group, and grabs a hold of me, gives me the biggest smooch in front of everyone. And I'm disassociative. I'm not doing well. And I talk about that in a classroom and I say, cool, I want you to think, just talk amongst yourselves for 20 seconds. Do you think that's a regrettable sexual thing? Or do you think that's overstepping the line? They talk, they come back. Some people think that it's maybe a bit gray, not sure, regrettable. Some people think there was a transgression. I say, yeah, awesome. I think it's a bit of a transgression. I still think about it. But at the same time, I'd love for you guys to think about, what if it's not a kiss and it's the next level up? What if it's not that and it's the next level up? Where do we need to have the conversation between that regrettable sex and rape? And I think bringing that into classrooms and that consent conversation, that's starting to happen, which is so good to see.
Yeah, that's great. It sounds like a bit of a yes, that the needle is shifting, and obviously lots of great conversations that you're having with young people in schools. Our time is nearly up. I've got kind of a closing question for all of you. The theme of today was around what better looks like for women's sexual reproductive health. In just a few sentences, how would you like to answer this question? I might go to you first, Catherine, around what does better SRH look like to you?
Thank you. It's a big question, but I think that better sexual and reproductive health really is around women's health being valued in society. I think it's around access. around taking into consideration the enabling factors that allow women to go and put themselves out there and seek healthcare. And yeah, I think it's just about us as organisations in various sectors, regionally, rurally, really getting together and trying to implement some of those recommendations that we have in our report to answer those lived experience requests for better.
Wonderful. Thank you, Catherine. Jack, closing sentiments. What does better SRH look like to you?
I think you've got to build that safe and respectful sexual reproductive health lens and framework. I think you've really got to advocate for an increase in that sexual and reproductive health service and the equity of access. Obviously, I'm biased because I work in the space, but I really, really believe that you've got to work proactively as opposed to reactively. And when you've got women's health as a proactive goal, as opposed to it'd be nice to have, let's actually put it up here where it should be, because that leads us to actually get some change, which would give so much more power and impact back to women, as opposed to them potentially being ignored, not having their health taken in the way that we know it could be.
Wonderful closing words. Thank you. And Siobhan, better SRH to you.
Well, from a health practitioner's perspective, needs to be in core, it needs to be across all disciplines, so that we can take up the challenge to be an accessible point for all people to approach their sexual and reproductive health, I think, and to have conversations, to keep having conversations. People who are passionate about it, go for it, but everybody should actually be able to have the conversations. Sorry, that's my doorbell if you can hear that. And I really think it's about us stepping up and ensuring that we talk about it, down, upstream, whatever the expression is, and educate ourselves to be able to enable access for the community. Sorry, the doorbell just completely put me off my sentences then.
Thanks, Siobhan, and thank you to all of our panelists. That was a really great discussion that I could have continued to have for much longer. Appreciate all of your time in joining us for this discussion. I'm going to hand back over now to Amanda to close what has been, I think, a great forum today.
Thank you so much, Ash, and thank you so much, Jack, Catherine and Siobhan. I could have kept having the conversation and listening to you all talking about this for a lot longer. I'm recognising that it is almost time to finish. We've got a couple more minutes. So I think this has been such a great discussion, highlighting the path to a more robust and equitable sexual and reproductive health system. It's really comforting to know that none of us are alone in the drive towards improving women's experiences and taking a step towards creating a gender equitable, person-centered and sex-positive environment in which people of all genders can access the information and services required for their sexual and reproductive health needs. So that brings us to the question of where to from here. Our three organisations, Women's Health Goulburn North East, Women's Health Loddon Mallee and SERSH, are committed to working collaboratively towards the goals laid out within the Long Story Short report and contributing to implementing its recommendations. Our findings have already informed the Victorian Women's Health Services joint submission to the Women's Pain Inquiry, and will continue to guide our respective organisations in our advocacy and community work in the SRH area. As was said today on a number of occasions, collective action between organisations within the women's and public health sector, research, healthcare, and local education and local government is vital to taking a whole of society approach to improving sexual and reproductive health in our region and across the state. The project recommendations are multi-levelled and focus on various pathways to improve sexual and reproductive health access for people from different sectors and communities. These recommendations will act as a guide into the design, implementation and delivery of future sexual reproductive health projects, programs, initiatives and strategies. communities. Everyone from medical practitioners, health promotion officers, educators, administrators, community leaders and decision makers are encouraged to use the key findings and recommendations to inform system reform and to reach out to the Long Story Short team at Women's Health Goulburn North East and Women's Health Loddon Mallee. Thank you, each and every one of you, for being with us today on World Sexual Health Day. I also want to thank you for your work in improving the sexual and reproductive health of women and gender diverse people across our communities. Whether you're a practitioner, a policymaker, or one of the community who have participated in our research work, and of course you could be both, you are making a difference and you are appreciated. So my final thing to say is that we will be sending a follow-up email, a link to further information, as well as the full Long Story Short report, and there will be an event evaluation, which we'd love to hear your feedback. If you'd like to speak to someone about the project or the report, please don't hesitate to reach out. Our details are on the screen, but will also be in the emails. Thank you so much for coming. On behalf of SERSH, Women's Health Loddon Mallee, Women's Health Goulburn North East, we wish you a fantastic World Sexual Health Day. Thank you.